Dr. Pratap, please join us. Morning, sir. I'm Dr. Srinivas Kumar here.
Hello.
Can you able? Are you able to? Yeah. I have Dr. Pratap Kumar and Dr. Sushant.
Yes, I can hear you.
Yeah.
Okay.
We are able to see you
and
hear you.
welcome. I think we are the opening batsmen, so welcome to the meetings of TCT India Next ACVS, and welcome from SGPGI. So we have actually two cases here lined up for you, and the first case is here with me, and on the second case is Dr. Goel. So I will just start with the first case. I'll ask Dr. Rupali to introduce Dr. Rupali from the Cardiology, and we have our assistant converting. Rupali also is the professor. So let's go.
Madhu, stay here. Where is it gone?
Yeah. So good morning, everyone. So we are dealing with patient 62 years old who is an ex-smoker, and he presented with us with class 2 angina for the past 3 years with increased symptoms for the past 6 months. His ECG showed normal sinus rhythm with normal axis, normal QRS morphology, and his echo was normal LV size with normal contractility with no regional wall motion normality. So with the diagnosis of chronic stable angina, with despite optimized medical treatment, he continued with symptoms, and we took him for angiogram. Can we come to the angiogram, please?
So can you show the angiogram, please? Come on. Angiogram, diagnostic angiogram, yeah.
Back, one back.
One back. Back, okay. Yeah.
So can you give us the radioarterial route with the lelocranial view? There was severe osteal left main stenosis which was involving the body, and overall left system was non-dominant, and there was no significant distal disease. Next view. So this is the other arterial view which shows some osteal left LAD disease, and L6 was free of significant disease. Next.
Screen pen.
So what you practically see here is there is a left main disease, long segment left main disease, maybe the ostium body, and going through the bifurcation and a little beyond into the main LAD. The circumflex looks open, and the distal vessels are okay, and we have a right system which is, can we show the right? Right system is having some moderate, proximally it has some disease, and this stenosis in the left lane is quite severe, so some contralateral filling is happening, as you see here. So it's very critical on the left lane systems, including the bifurcation and the proximal part of LAD. So that is the case. So I was just wondering if you have any thoughts how you would like to proceed with this patient. So you can let us know. Okay?
Yeah.
Any thoughts on it? Yeah.
So, go ahead. So just for the audience, can you tell us what the system you have set up is? It's a 6 French radial or 7 French? Do you have any other additional access?
Yes. So you see, I just want to show you this. I just want to show you this for left lane. I have a system here where I have a 6 French outside diameter sheet which takes a 7 French inside. So I have a 7 French guide. There is a 7 French guide, but the sheet is green. It is 6 French. So this is from Terumo. Actually, they have made a new sheet which is somewhat thin walled. You can see the detail on the slide there. So what happens is the normal sheet is about 0.2 mm thickness. So if it's 2 mm inside for a 6 French, the total diameter of the sheet when it goes in is about 2.4 mm. Now a 7 French is 2.3 mm. So here you have a sheet which will take a lumen, inner lumen of 2.3 mm inside the sheet. So the 7 French will go, but the outside diameter wall is thinner, it's about 0.12 mm. So you do not have a much bigger size on that. Well, this sheet has just arrived, so I thought I will use this. But earlier I started, whenever I needed 7 French to a radial, I would do it without much hesitation if I have a good pulse. I started with seeing it on ultrasound, the size of the artery is more than 2.3, 2.4, and most of them are. So they will take 7 French, so we used to do it with that also. And then just by feel we were doing it, and we have had reasonably good experience. But now with this new sheet arrival, so we are using 6 French sheet for a 7 French guy.
And also we had a little bit of...
For left lane, you do not really need...
No, we had some difficulty with the video and audio to start. Could you show us that spider view one more time? It's a true bifurcation lesion or not?
Okay. Yeah, you see, as I told you, it involves the left lane distal, it involves the ostium of LAD, but the mouth of circumflex probably is open. Can you show the views that we have done? So now these are the diagnostic views that we have done with the guiding catheter. If you see, can you show the views from here? Yeah. Yeah, so now we have a biplane system set up. Actually, I am working on a biplane system. So I have some advantages to the biplane that I envisage, and so I use it. So we have the ostium and the body of the left lane. And if you show the next one, the previous one, yeah. Now if you see in the RAO view, in the RAO portal, the disease is extending into the LAD mouth. Because if I restrict my procedure to the left lane, I will probably not get the right result. So all my stenting techniques have to go beyond, so it becomes a bifurcation.
Dr. Goel, it's
a... open, we will see how we handle it.
Basically, Goel, actually, when you see an angiogram, you should see that a complete bifurcation into one projection. Ideally, in this case, if you go and...
Yes, I agree.
But if you see in the angiogram... No, my question is actually to show that you show a projection which can easily say the ostium of the circumflex and LAD properly. But none of the projection showing a proper ostial circumflex and ostial LAD. I preferably go for a LAO 60-40 where you can see a bifurcation exactly to identify whether it is a one.
I have a little limitation. Dr. Prasad, the thing is, because of this biplane, I have a little limitation on the angle.
Okay, thank you.
I have a little limitation on the angle, so I have to compromise slightly. That is the reason. Otherwise, I could show you all.
Sure.
I hope you realize.
Sure.
Because we're working on biplane.
Okay.
That is the downside of biplane, that you have some limitation of angle.
Okay.
And we will do IVUS and we will be able to see how much disease is there in the ostium. So I think we can do the IVUS. No, so let us do one IVUS run, there's no problem. Let us do one IVUS run.
You will do an IVUS.
I will do IVUS run through the LAD.
Will you do an IVUS to the circumflex also?
That will show us the LAD.
No, my question is, will you do an IVUS to...
Yes, I do to the circumflex.
In this case, I will preferably to do IVUS LMCA to circumflex than to LAD, because LAD I know there is a lesion, but in circ...
Why?
But I would do it both LAD and circumflex, because the LAD disease goes... Right.
He says he'll do both.
Yeah, yeah. The LAD disease looks like it goes to the bifurcation. Yeah.
Circ disease is not clear. That
Okay, come on.
Basically for...
Sure.
Okay. So the IVUS is just going in. I'll show you the IVUS withdrawal from the LAD.
I mean, one of the challenges in this case as well is a very short left main with proximal LADs as well. And ideally the strategy, as you said, would be to cross over the circumflex. And if there's not disease in the circumflex, it becomes much easier, but you have a very short left main as well.
Yeah,
Can we see
the IVUS? So now you see that is in the LAD.
Can we see the IVUS screen, please? We don't have IVUS.
Can you show the IVUS, please? 1, 2, 3, 3.5. Can you show the IVUS, please?
Yeah, we're
Okay,
able
now
to
we see it.
Flush down.
Oh.
Just hold on, please. So the IVUS is being seen there.
Where is
Okay.
that? Is that in the LAD right
I'll
now?
pull that. That is in the proximal part of the LAD. That's a diagonal vessel receptor coming up.
Wow, wow.
Now you see the amount of disease in the LAD.
Yes, a
You
lot
see
of
it's
disease.
very severe. You see that?
Oh.
There's big amount of chunk of clot
They-
there. This is
can we get the
all
IVUS back on the
part of
screen,
LAD
please?
And near the ostium. And that's the circumflex coming up.
Got
That's
it.
the circumflex coming up. And that's in the left main. It's in the bifurcation point of the left main. Circumflex probably is open. Then that's all disease in the left main. And that's the amount of the... Now you see I have a guiding catheter which did not have any holes. So, and the pressure is okay. So probably the mouth is open. You have it in the body, the bifurcation point and the LAD. And we can see the circumflex also. And then I'll get you to the other side. Okay?
And but even here, you see that the circumflex looks relatively clear, but it's better to IVUS from the circumflex, but the ostium and the circumflex as
Yes,
it comes in.
looks, but unless you pull back from the vessel, you can't really make out exactly what is happening.
But in the pullback, we
So
can tell
you get
that
oblique views otherwise.
ostium is
So we have a
circumflex is
pullback.
devoid of disease. In the pullback, but if you really see
Yeah,
that,
let's see. We will make our decisions based on that.
yeah,
We'll make our decisions based on that, okay? Because left main, you know, whatever it is always almost being treated like a bifurcation once you have to go beyond the left main into the LAD. Now the strategies will vary depending on how the circumflex is. So we have to...
The one other thing I would say
Just a sec.
for the other interventionists here is that I know cost is an issue, but I think if we're treating left main, I think it's imperative that you IVUS, because we're comparing ourselves to a surgical lima, which has excellent results.
I
We have to
totally believe in
optimize.
that. I totally believe in that.
New run
New run to the circumflex.
to circumflex.
but the strategy is crossover technique now, right? Single crossover technique, single stent, right?
Okay, so that's the circumflex being seen. So the circumflex distally from the point where we are starting is okay. So there's no disease there. And now we start the pullback. So that's the pullback of the circumflex coming up. So as you will reach the mouth, probably it is open. That's what I thought angiographically. Let's see.
There's some negative remodeling there, you see as well.
Plaque.
Minor plaque is there, minor.
So I think the circumflex is open.
Yeah.
So the circumflex
Not
is
in the
open.
left
Okay?
Yeah.
So this is 110 as you call it. You see, all these are bifurcations. So this bifurcation is 110. It is not 111. That I agree. Okay?
Yeah.
So this bifurcation is 110. So now having seen this, my thought is I will do some balloon, probably a cutting balloon. I prefer cutting balloon on ostial diseases because left LAD ostium is involved, and so I'll do some ballooning and stuff. In the meantime, I think you can go to the other lab and see what they are doing on the other side. They have a calcific LAD lesion and some OM disease. So if you want, you can switch to the other side. Srinivas?
Yeah, okay, sir.
Yeah, hello?
Yeah, sir, we are back with you, sir, now.
Srinivas?
Yeah, we are back with you. We can see you and hear you. Please go.
Okay. Okay.
We can shift
so
to the
just
L6
show
ostium.
so you
L6.
saw the IVUS and you were clear that the LAD ostium and a proximal part of LAD is diseased, left main is diseased, and the circumflex ostium probably was okay. That's
Can you
where
show
we
the
left
L6
you.
ostium?
Is that clear?
Yes.
So what I did was I did a cutting balloon on the ostium of the LAD and left main area.
Which one? Flex
I
dome?
prefer a cutting balloon here
what is
because
it?
what?
Which
Yeah,
balloon?
flex dome. Yes.
Can you just show them?
Show the. No, not on the picture, not on that.
310.
It is 310.
310 we used.
When I did the IVUS, the LAD
L6
size
ostium.
was 3.5 distally.
Okay.
The left main is about 4. Okay.
Okay.
So with that 3.5 and 4 and the little long segment, I thought let me underplay a little on the cutting on the balloon, and I have done it with a 3.0, which is reasonable. 3.0 into 10 cutting balloon. Can we see
Can we have the
cutting
IVUS
balloon?
image? Cutting balloon.
Actually, in general, that's a
Cutting
good
balloon.
strategy, I
so
think.
that is what
Whichever-
I did it towards the LED.
Yeah.
Yes, because what happens when you do
One more
when
back.
you do with a cutting balloon, you don't produce too many dissection flaps, and especially some of these osteal lesions are fibrotic. You try to blast them with a regular balloon, they do blast, they do open, but then they tear apart on the other side, and all those things happen. That's what produces dissections. So I know that the circumflex is preserved for me right now. So I want to maintain it preserved, and that is the reason I did it with a cutting balloon. That's the cutting balloon, first a little distal, then a little proximal to cover the entire area. And after the cutting balloon, we have the angios. So that's the cutting balloon.
Only problem with the cutting
And you have
balloon,
to
Dr.
go up,
Goel, is sometimes
slowly
if
on a cutting balloon.
sometimes if the lesion is too critical, these balloons are slightly more bulkier than the regular balloon. You may find it difficult.
It will not go.
Yeah.
It will not go.
But
So you have an answer to that. You do a 1.5 small balloon
Yeah,
and
that's
then
what.
do a cutting balloon.
Okay. Did you do that,
You
or
do
it
a
is
small
cutting balloon?
1.5 balloon, create a channel, and then do a cutting balloon.
You
No,
did-
this went in.
Okay. Okay.
This went in straight.
Okay.
So now I'll just show you on this picture. Just on this picture, if you just run it, this is one of my advantages of biplane. You are seeing the biplane, and you see the LED wire looks very much like it is in the LED. It's in front. But when you see the LAO, it is in the diagonal.
Yes.
So without any more contrast, you'll just put the wire back into the LED and not the diagonal. So there are a lot of advantages I get in biplane. So I just wanted to highlight that also. You can wire without contrast. Because you see, keep switching between the two planes, and then you know where the wire is going. And especially in CTO cases, of course, I use it a lot. So that's the advantage. So I know that's just by the way. Go forward. So that's the result after balloon, cutting balloon. We see a RAO cranial view. Next forward. Now this is the, I think there's one more. The guide was out. One more. So that's the cranial view. Okay, stop. So that shows the thing. So we have disease. So the ostium probably is open, and the ostium of the left vein is best seen in a cranial view only. I think this I always say, and you will see it here that the ostium is open. That's why my guiding catheter was not damping. And then we have body, and then the LED, and then when the first septal comes out, before that there is disease. So that is the length. On IVUS, have we measured the length? It's about 18 mm or something.
Say about 20.
So
20.
I thought I will. So what next? So now, if I want to avoid the circumflex stent and plan for a provisional stenting, in a case like this, you can do it because the circumflex was open. And so I
Can you
think
see
we
the
can have a
L6 osteon
crossover
IVUS?
stent, if it's okay with you,
L6 osteon
from
IVUS.
left main to LED, and
Yeah,
then we'll
I think
decide
if-
on the size of the stent. Is that okay?
If the LCX
Any
is free
thoughts?
from disease, I think you can do crossover stenting. I wanted to hear from you, suppose the left main is long and the
Yeah, I think.
ostium is free from disease. Do you mind covering the entire length of left? I'm asking, if your left main only has a distal
No, I
disease,
will not do that.
you will
I'm
not, will you cover the ostium of left main, or you'll
And there is more disease.
okay, only from the normal segment in the left main mid portion?
Well,
you'll
I
do this.
will. No.
Here,
very
I think
few
the
cases
left
I
main
have
is
done
small.
like
Anyway,
that.
you need
That's
to
only
cover.
if there is an ostial.
Here, I think anyway you need to come into the ostium
No,
because it's
even
very
otherwise,
short left main.
Even otherwise,
Sir,
there are two things that I always do. Largely, I try to cover the LED, the
Ostium.
left main ostium, the LED ostium. Means I always have a crossing. Just restricting it to the left main is not very easy.
No, I am
Unless
asking.
it's a pure ostial stenosis.
Yeah, I am
Unless it's a
asking
pure
about
ostium.
the ostium of left
And-
main. If it is free, anyway it will go into LED here. But you generally cover the left main ostium if there is any distal disease also.
Okay. Left main ostium.
Yeah.
No, I will leave it free. If the left main ostium is free, then I will not cover it.
Okay.
So we will see how we place it. So let us, if it's okay, I'll get the stent. So
Pratap
let
has
us get
something to
See, I have two
the
doubts.
LED was
Goel, I have
3.5,
two
24.
doubts. Hello?
Let's get ultima.
Dr. Goel, Pratap has something
Goel,
to say.
can,
Yeah,
can,
follow.
can see when you put a stent
Yeah,
from LMCA
yeah.
to LED, and if you have a LMCA is less than 8 millimeters,
Then it's not possible.
a port is not possible. I personally feel that you have to cover from the LMCA ostium to the LAD.
Here-
Otherwise, port is impossible in this case if you don't cover the ostium, because LMCA looks like maximum of 8 millimeter size.
I was going to make the same point. I think the challenges
Right.
often are that you have a size mismatch between LAD and your left main. And you're going to have to do pot in all of these cases almost because there is size discrepancy. So
It's showing 20
I
and
generally
how much
favor
is the
covering to the left main so you don't injure the left main as well.
When I say 18, I had guys. Let us do it 20 millimeters. Let us do
Osteo
20.
left main to the.
Let us do 20 millimeters.
Okay.
3.5, 20, come on.
I think,
Come on, let's get...
Dr. Goel, what you said is in the long left main. Here, the left main is short. Anyway,
Yeah.
you need to cover the ostium with, right? What
let's see, no, because...
you'll go into the LAD.
No. But you will cover according to the anatomy.
Yes, yes.
Which is, you will cover according to anatomy.
18.
I don't think there are ways to cover. I will not want to. Please, yeah. You see, I will cover according to anatomy.
Okay.
Whatever the anatomy calls for, I will do accordingly. So let us see.
Okay.
Let's see. I'm going to do it. You can see what I do. Whether I reach the ostium or I don't reach the ostium, I am also not very sure. We have
Yeah,
some
but it's
water
too
here.
small here.
I think for the audience,
So I have taken a 3.5 20 millimeter long stent. I have taken a 3.5 20 millimeter long stent. Okay.
Okay.
3.5
The
to 18.
length of disease on IVUS was 18.
Should be more.
3.5 20.
I personally feel should be little more than that.
3.5 20.
Is 20 length enough? That's
Let's
what
see. Let's see. No problem. I'll change it.
Okay.
I think 20 should be enough. You see that now.
It will be just okay for the
That's-
lesion,
that's
but
where
actually
the
whether to
assessment
port
comes.
you can do or not.
Let's see. We will see it. Test, please. So it's going well beyond the normal part. 20 is also long.
The proximal portion?
Can you?
The proximal portion of the stent.
Everything is covered.
Yeah. You need to see in different angles.
Can we see
Let
LAO
me
cranial?
see. Let me see.
Yes.
Yeah. I will see. So
What
this
are
is
the
biplane. Just a sec. Okay. Oh, you check here. What have you done?
Nothing, sir?
The lesion stent, if it is
Make it
there,
electric.
some part of mild, sometimes it tends to milk out into the
Okay.
other segments. It's better to come proximally, cover it well.
Angio biplane, please. Come on.
A little proximal, sir.
I have to pull it back. So now this placement is little important, and you see, because my guide is also sitting there, I have to cover
Some of the
these
challenges here are
nearly
as you
the
pull the stent
ostium.
back, you suck
Now
the
which
guide
view?
in.
Now you see the aleocranial.
Yeah.
If you are, yeah, that's right. If you see the aleocranial, I think the best view is aleocranial. I think that's another thing which can be.
The ostium, for the ostium of left main,
Now only the.
to
no.
see to the left main.
Yes,
aeroplane
yes.
best.
Both the views, please. Inject. A little more. I need to pull it back a little
I
more.
mean, I think in this case, you essentially want the dot
Yes,
in the
please.
aorta, so you make sure you cover all the way to the ostium.
Yes.
Yeah, that's right. I am almost nearing the ostium. I am almost nearing the ostium because my disease is calling for it. Not because anything is short or long, because my disease is calling for it. Inject, please. Okay.
Little
It's
maximum.
still missing.
Yes.
Still missing.
Little 1 millimeter.
Test, please.
Yes, sir.
Yeah,
No,
I think
this
it's
is
fine.
Test.
Okay. Okay. Yeah, it's fine, sir.
Is it fine?
Yes, sir. One angio, sir.
Biplane angio, please. Come on. I think this
it's
is fine.
fine.
I'll do it. Because I believe on the aleocranial
Yeah.
for the position of the ostium.
You did it negative?
Huh?
Negative, yes.
Chalo, we have not done negative. Anyhow. There was
I was ready, no? Saline delay, sir, please.
Is it too much into the aorta or is it okay?
Stent. No, it's not in the aorta. I'll show it to you.
Okay.
It's not in the aorta. It's just at the osteum, I think. It's
Can
just
take
at the
one
osteum.
cine in one-
And I believe in the LAO-cranial view to highlight the osteum. I'll show you the cine. I'm just pulling out the stent and I'll show you the cine. No worries. Okay. Come on. Biplane, yes. So there it is. So, stop.
I think so.
So we have, now you see the osteum is covered, looks a smooth transition,
Could you give an idea?
and we just run the angio, just run it please, the lower one. I think it is okay. We'll now do some IVUS run, I think.
Are we going to NC POTS now, sir?
I'll do some proximal port to the left main with a 408 NC first. Okay?
Yeah.
And then I'll do an IVUS, because if the circumflex is open, now the issue is whether should I dilate the side branch stent hole towards the circumflex or not. What does Dr. Sushil Kudali say about it?
For it?
I
What
think
is
if you
his
have
thought?
good flow, I wouldn't open up the circumflex with such a large vessel, but I think there's
You won't open up the side
both
hole?
ways to do this. I would do the
Let me
pot
see
first
the-
and then IVUS. But the question is, would you rewire the circumflex?
Yes, that's
before
what I'm
posting?
thinking. So 408.
And there is a data published also, a kissing balloon inflation is not treated if you are not putting two stents at all. Number two, a single stent strategy, you don't require a kissing balloon inflation at the end.
Yes, sir.
Come on. inject.
Rather, it can create more maze than the other way around.
Looking good, sir.
So if
But
you
I
see
think
the
you
AP
rewire
card,
before
it's
you do
looking
pot.
good. So,
For it.
Rewire
So
through the
we
left
have a
main before you do
4-8.
pot.
No, I am not going to rewire. No, I am not going to rewire before I do pot.
If he
Because
wants, he
the
can take
purpose
out
of
the wire
pot
and
is
finish it off. I think
so that I
before putting
don't
the
get into
port, ideally you rewire it too. Before putting the port, actually the proximal optimal dilatation,
No, you see,
you really require the wiring into the circumflex, and then it is always convenient
No, no.
if you wanted to go ahead,
There
you
is a-
can do it.
no, I'll tell you something. I don't want to handle the stented part before pot at all. Why? So that at least, so that I can fix the stent on the wall and I don't get subintimal, means under the stent struts when I start rewiring. Okay?
That means
So
you are
I
not
will
going for a
first do
port
pot.
at all.
And then only,
He's doing 4 mm. balloon.
You're doing a
this is the pot coming up.
okay.
Okay.
That is 40. That is
4012?
40, high pressure NCs have gone up to 408
8. Okay.
because I don't want to get into the LED.
Yeah.
So this is, I've done it till about 18 atmospheres because we have already increased the size of the left main from 3.5 to 4, and so that is what I have done. So now I think I will see a IVUS into the LED.
Dr. Shivkumar, you can join us.
And
Please.
well, I can, at this stage, I can also rewire the circumflex. There is no issue. I think I can
We can do the
rewire.
first IVUS, sir.
No, let me rewire the circumflex. Give
Can
me
you
a
have
few
one
wires.
Actually, before
So that
we do
now
pot,
I'll rewire the circumflex.
sir, generally, discussion was you rewire the circumflex through left main before you do pots. Is that
Before?
okay? Is that?
But then if you do before, then no. I'll tell you the reason. If you do it before, then what if your second wire goes under the struts of the left main?
Okay.
Then you have a problem.
So you're not worried too much
So one
about
of the purposes of pot is that, no, I'm not worried about the jailed wire.
Okay.
I'm not worried about the jailed wire. It will always come out.
Okay.
See, but he is not worried. I think
I'm not worried
before
about
doing
the
the pot, we have to take the wire out and rewire to the circumflex is ideal. Even if you have kept the wire in the circumflex, nothing is going to happen because the vessel will accommodate. I think this can accommodate 4.5 millimeter in the proximal part of the LMC.
So now I am through the struts into the circumflex.
So distal wire, I think, is in the branch.
The jailed wire can be removed.
Yeah, I'll now remove it. I'll remove it in front of you. Where is the jailed wire? So now that's the identified jailed wire. You see how smoothly it is coming?
Yeah,
you see
most
that?
of the time because left vein
No
is
issue
very
at all.
low. Yeah.
I have been doing this since 94, I think, if you no one used to jail wires in bifurcations, I used to jail them. So there is no problem in jailing them. If you remember, in 90s, the concept was never jail, but now people are jailing it.
We can do IVUS run, sir?
Okay, can we do an angiogram now?
Okay.
Biplane, okay. Just a sec, the hooking is not good. Okay. One angio, please. Okay. So let us see the
IVUS, sir.
IVUS.
Flushed.
So IVUS towards LAD.
Angiographically, that portion still looks little under left main compared to LCX.
Which one?
Is it a present one? What we are seeing
I don't
here?
know.
is,
Let's see.
LCX.
Yeah, this is the last angio. you
Yeah,
see.
yeah. Okay.
LCX.
Maybe LCX is little ectatic here compared. It almost looks like left main. We can do IVUS and then decide.
Okay. Okay. Come on. So we'll have the IVUS live. Okay. IVUS live, please. So there's some distal to the stent. There's still mild plaquing. That's okay. The size is 1, 2, 3, 3.5, 3 point. Yeah. So withdrawal, please.
Withdrawal.
Pull back. So but that is independent. Now, as I come back, there is less disease. So I have put my stent in normal to normal, so-called. So this is normal. So this is normal. Some mild plaquing, a diagonal type vessel coming up, and then the stent. So stent is absolutely in the normal segment. It's reasonably well opposed there, and we have that septal coming up there, I think. The expansion looks okay for the stent. It's a little under proximally. I think I'll do some more.
3.5 NC, I think.
It's little under proximally.
Even angiographically
So I'll
also
do
it
some
will look
NC here also.
Hey, the LCX Astra.
Oh, yeah. So I'll do some NC here, and then that's the circumflex that's come up, is it?
Left main.
Now in the left main, I think I'll do some NC proximal part of LAD. So maybe we can use the same 4-0.
Yeah, because
I think
approximal
we'll
LAD is 4,
yeah.
sir, actually.
So we'll use the same 4-0 NC balloon
Same one.
and do some proximal this thing.
The
And now
proximal
my
left main-
circumflex wire is
The proximal left main probably needs
Yeah.
a 5 mm balloon.
2.5.
Dr. Goel? Because we did already with 4
I don't
NC,
think
already
so.
with, we've gone up to how much pressure? 18?
yeah, I went up to 18, I'll give a little more. So let me see,
Shift
okay?
control?
Isko fix, just can you fix the wire for me?
Yes, sir.
Okay. So, actually a 12 mm balloon would have been better. Anyhow.
The advantage of later generation stents is basically they have a differential expansion capacity. They are doing part, still they can adjust, and unlike the previous
Let me
generation
know, balloon.
where you used to
412?
have
412.
problems.
412.
But even angiographically it looks little
You
less.
see,
IVUS also
get me a
confirms it. I
412.
feel you should have taken a 5 balloon and do a proximal part, or at least 4.5 if available.
Well, 5-0 is a little big because my
in left
measure
main-
of the, what was the left main on IVUS?
This was a worry if you don't cover the ostium.
4.6.
If you cover the ostium well, then probably you can be aggressive in dilating properly. Now you leave the ostium,
show the left main?
you're always worried whether it'll dissect at the junction of the...
That is one of the major point. Actually, if you are not covering, you may land up in problem of the LMCA.
No,
posterior
but I have
part
covered
dissection.
the ostium. I'm not worried about that.
You have to take a balloon and a high pressure dilatation is required.
But whenever what we have noticed
So
with
now
NC
I'm doing
balloons,
it.
once you inflate once or twice, the the property of it is goes
4.5,
actually. It doesn't
4.8.
decrease further unless you take a new balloon further. Again. It becomes like a gas.
And just show the last left main post-stent.
Okay, so you
Now
see
the
this is
latest
proximal
recommendation is not to take a non-compliant
NC
balloon.
dilatation.
Take a semi-compliant balloon or a compliant balloon for a post-dilatation because that can expand the vessel. Otherwise, the non-compliant cannot expand too much. We take a non-compliant balloon, which is usually
Dr.
happening.
Goel, we have another 5 minutes of transmission. Is it okay? Shall we go to the other lab and
Yeah.
see once?
Yeah, that's fine. That's fine. You can go to the other lab and come back. You can, I can show you the final whatever, okay?
Okay, sir. Do we have, can we switch to other lab just to see what
Just show the
they're-
left main, proximal part. Last
Dr.
slide.
Goel, we are with you. We are here to see your
Come on.
final shots.
Six. Yeah. I have done some post dilatations after that.
You're doing
and
IVAS
I'll
now?
show you the final picture now.
Okay.
This is the IVAS, yes. So I did it with 4 and I have done with 4.5, a little lesser pressure though on the left main part.
Yeah,
okay?
that's what we were feeling. It takes a little bit.
And
Okay.
Okay, imaging.
So it's important that the guide there, you see
You
the
pull
guy
back?
is disengaged
Pull
now
back.
when you're pulling back, which is important.
yeah.
Little this. Okay.
Is it coming back?
Yes, it's full.
Okay. So this will LED. How far? is
Yeah,
it?
stent, sir.
So that's the stent starting there.
Yeah.
So the size looks okay. It is opposed. The as I come more proximally, again the size is okay, which was looking smaller earlier. So it's a little oblong in shape, but that's not an issue.
L6.
And that's the LCX,
LCX
that
osteum is
that's
okay.
coming
Definitely looks
up.
better expanded though.
That's in the left main. Now that's the left main. So that's a very good expansion in the
1,
left
2, 3,
main.
4, 5. Right.
Opposed, and we have at least a 4,
Osteo.
and we are now reached the osteum. The
Okay.
guide is
It's
not there.
a very nice result.
So
The
I
stent
think,
goes right
and
to
the osteum,
Perfect
true
positioning.
osteum is free of stent. Just show me the true osteum.
Yeah, that's
Go
what
back.
we were
I
feeling.
want to see whether the true osteum was
Image
free
review.
of stent. The true osteum is free of stent, and because it has no disease, if it has no disease, I will not put the stent on the osteum.
More proximal.
Go back.
Yeah.
Yeah. You see that?
Back.
Yeah.
The stent ends there, and then further back.
Play.
Matlab the last withdrawal till we are coming out, till we are out. You see stent struts till we are out of the stent. And now,
Okay.
still we are
Wonderful,
out.
wonderfully
Still further,
done,
yes,
Goel.
So no stent there.
Yeah.
So that is absolutely on the osteum place. Okay.
Okay, that's a very good
So I
demonstration.
think with this we can end this procedure.
Okay. Thank you very
Yeah.
much.
Thank you.
Thank you,
Thank
Dr.
you.
Goel, Dr. Rupali, and all the team. Thanks for the very good live demonstration. We learned
showed them
how to do a left
Thank you.
main intervention image guided through radial route, though he showed usage of 7 French catheter through the new thermo sheath of 6 French. And in the other lab, we learned about how to deal with really diagonal bifurcation, and especially when there is calcific disease. He also demonstrated as how to use the biplane, if at all, if it is available. Thank you very much, Dr. Goel. A big round of applause for Dr. Goel and his team.